what I want to ask you a question, first of all, is who's heard of artificial intelligence? Everybody? Everybody heard of it? Or no, never crossed your consciousness in any way whatsoever? Okay, fair enough. So what I'm going to do in the next 5 minutes, and maybe 1 or 2 minutes more, is I'm going to take you through what it is in a relatively straightforward way, because it is complicated. I'm going to talk about the way we're going to use it, and I'm going to go through a couple of things that have been done with it already, and finally just finish with what's actually possible. So this is a lot of this comes from this book. If you ever get a chance to read this and you've got any interest whatsoever, this is a book by a Californian pediatric emergency physician, and gives a really simple, straightforward, and a really good introduction to artificial intelligence. So, most people now, in the last year or so probably, have heard of this. We've heard about OpenAI, we've heard about DALL-E, we've heard about GPT-4, sort of every day it's in some sort of news item, it's on the blog or whatever, talking about, what AI does and how scary it is and all those sort of things. Well, these are things called large language models, and they are immense, they are huge, and I don't propose for a moment to talk about how they do stuff, but suffice to say that they use billions of pieces of information to learn how to respond to a fact or to a phrase or to something else. And they end up looking at how all the data in the internet, for instance, has responded to one particular word, and it has the statistically next best probability. So I thought, well, we'll have a go at this, all right? We'll try to use ChatGPT. So I did. And I was going to do a talk on AI and head trauma. So I got ChatGPT up, and I put in a query. It said, tell me about artificial intelligence and head trauma. And this is a real-time screen capture. That's it. And that actually is, reading through it afterwards, is a pretty perfect rendition of the domains of interest in artificial intelligence and head injuries, which we'll go through in a while. It came up with diagnosis and imaging, predictive analytics, rehab and recovery, decision support systems, and personalized medicine. So we'll talk about that a little bit later. So this guy, Marvin Minsky, is well known in the area, and he said it's a science of making machines do things that would require intelligence if they were done by men. And Alan Turing, who's famous, there was a movie about him a couple of years ago, you may remember, and he said essentially that the idea behind digital computers can be explained by saying that those machines are intended to carry out operations which could be done by a human computer. So they're attempting to mimic the way that humans think. And he asked the question, are there imaginable digital computers which would do well in the imitation game? Now, what the imitation game is this thing. And because it's really tough to actually work out whether AI is AI, and certainly some time ago, what he devised a test where it's more about trying to figure out, a human trying to figure out if the output from a person or a computer was different. So he had a computer and a person behind a screen, and communicated only by text, and he asked them questions, and the questions were what would differentiate. And basically, AI has consistently failed to actually be taken for a human in this imitation game, and the Turing test is still just about thought to be the differentiator between humans and AI replicating humans. But it is a complicated thing. There's lots of different sorts of lots of different domains in AI. But the point really in all of this is to try to use techniques to deliver usable information from data, from information, and to actually join up in the end causes with effects. And all of us here do that every day. And in actual fact, experienced clinicians do this every day without thinking about it. Everybody here, I'm sure, has actually had a patient and they've given a history and it sounds a bit innocuous, but you've gone, look, I don't know why, but I'm a bit concerned. Everybody does it, okay? And you do it by using lots and lots and lots of pieces of information, often that you don't even know that you've recognized, and putting them together in a pattern recognition sort of process, which gives you something that tells you there's a problem, okay? What it's trying to do is do the same thing eventually. Briefly, there's some different types of AI. We'll go through some of them. There's machine learning of different methods, there's neural networks, and there's natural language processing. These are potentially some of the most important things. Machine learning really can be, again, divided into different bits. Unsupervised learning essentially takes data and divides it into domains, into different areas on some characteristics without being told how to do it. And that actually is what machine learning is about. It's about a computer being able to divide up information or describe information without being told any rules. So it makes up its own rules. Supervised learning is when you tell it what you're looking for, essentially. So you describe the fact that these patients have had an MI, and the machine will look at the characteristics and it will match them up to the ends, the MI as an outcome, and it will tell you in the end all the different characteristics that may point you to that as a diagnosis. And reinforcement learning, where it does that and then it gets a sort of a bonus for getting it right. So it reinforces that and it does it again, and it does it a bit more effectively than another bonus. So it's teaching itself to be more and more right all the time. Now, traditionally, when you do programming, you give some rules to a computer and the output depends on what you've told it to do. As I say, in machine learning, essentially the computer doesn't do that. The computer does it and then it tells you what rules it used, basically. The different types, again, very briefly, there's classification and regression. In classification, what it is doing is taking data, taking information about something and putting it into different groups, which means something important. Let's support vector machines. This is about drawing a line or a border between two sets of information that are different to each other. Bayes is the thing, does the same sort of process but on probability. And then decision trees, these are the foundation of lots of machine learning, and actually quite conceptually simple, because all it's doing is taking a question, and if the answer is yes, you go that way. If it's no, you go that way. Then there's another question and you go yes and no, and this is what the actual program does. And that whole system leads to much more and more complex sort of ways of doing things. Decision trees, they call them, leading on to various other techniques, but they all depend on that sort of making one decision and then following a track down there. Reinforcement learning, as I say, you take a whole mass of information and the program, the algorithm processes it, and it looks at all of this data and sorts it into various domains. And then there is a reward. As I said, the best action leads to a reward, so it knows it does that again and again in a more and more precise way. Neural networks are really getting to the point where AI is different to everything else. Neural networks really try to mimic the human nervous system, the brain that you use every day with patients. And they essentially have these nodes, they call them, where there's input and there's output, and then there are various hidden layers. And what that means is you put information into it, it goes into those nodes at the beginning, and then all of them communicate with each other, just like neurons do. And it means that information is shuttled back and forth between these, and excuse me, and it's processed, and more information, accurate information, is gained out of those data points. Deep learning is when there's more than 3 of those hidden layers of neurons, just like this, and you can see how complex that's getting. But this is actually one sort of in action, and it's trying to match up an input to an output, essentially, and as it goes on, it gets more and more accurate. But modern deep learning have huge numbers of this thing going on. Things like ChatGPT, but also the chess-playing computers have hundreds of layers and neurons all connecting to each other. And this is, again, a representation of a model, of a deep learning model. And each one of those sort of panels is a layer of neurons, and they're all connecting to each other. This is fantastically complex stuff. But the notion behind it still, in the end, is not that bad, not that hard. Natural language processing is fascinating. Now, every one of you probably interacts with natural language processing every day. If you say something into your iPhone and Siri answers you, that's natural language processing. If you start to fill in a form and it has your first name in it, starts to put in your second name, that's natural language processing. And it's recognized, the software, the algorithm has recognized what you've put in, and it has come up with the most likely next thing to put in. Okay, so almost every form you fill out on a website, it will be using natural language processing. But essentially what it does is it looks at huge databases full of text, and it looks at various words. It doesn't really work out what they mean, but what it does is looks at where they come in there and what other words it's in relation to. So they actually look at vectors which connect up words and what are the most common things. And so it's just a statistical probability those words are going to come next. But again, it's fantastically accurate now. And even things like dictation that we use in clinical settings use AI, use NLP to actually be able to process it. So how can it help us? Is this just really tedious and boring? Possibly. But it's going to be part of everybody's lives, okay, in a good way, I think. I want to just briefly divert to this. All of us, again, we're at this conference, so therefore we appreciate the fact there is a thing called a patient journey. Yep. We know that people get sick or injured when they get sick or injured. They don't get sick when they're in the ambulance, when they arrive in RED. They don't get sick when they go to ICU or theatre. They've got a whole journey which is theirs, but we break it up, unfortunately, into lots of bits and pieces. And although, of course, they might have all of these different things, for them, for a patient, every bit of this is seamless, okay? If you're the person who's just broken your leg or had a heart attack or whatever, everything here is seamless, but we break it up into silos. Every single bit of health is developed in silos, and that means that all of the information is in silos as well. If you've ever tried to get information out of, say when somebody went to the operating theatre, or maybe from the ambulance, or from a GP, you'll realize how difficult it is because the information is not built for us to actually all read it and understand it, even though we're dealing with a patient. So what we've tried to do, and at Liverpool, at the Ingham Institute, is we've taken all of this and we've tried to join it all together. The issue is that this is not new because most healthcare domains have evolved separately. The electronic medical record, of course, has made things hugely more difficult. And we've got this coming now, of course, big data. This is 300,000 people at Woodstock. I thought you'd like to see that. And the reason I thought you'd like to see it, because it's similar to this. The Golden Gate Bridge Walk that nearly brought the bridge down, the Southeast Island Ploughing Competition from 2018. And this. This is the number of patients that we see in the emergency department in southwestern Sydney every year. So some scale of numbers, and we need to know stuff about them, don't we? If that patient comes to talk to us, we need to understand what the problem is, but we need to think about the context and their history. If they had a heart attack before, they're at high cholesterol, do they smoke? All of those things we've got to try and take into account in all those people. And the reason I put this up is because we're just about to be hit by a tsunami of data. Although you may not realize it, the EMR and all its component electronic bits, medications, fluids, all the monitoring data, imaging, for instance, virtual care from COVID, of course, has given us a whole other area of data, and sensors. Everybody's going to be wandering around wearing sticky sensors soon, and it's going to be processed by AI, I can guarantee. But the point of it is, data comes from everywhere, and it's exponentially growing. There is an estimation that from 2022 to 2025, the actual amount of data is going to double. Total data in the world is doubling. That's in 3 years, and we're halfway there now. And that's equivalent to 180 billion 2-hour movies or 1.1 quadrillion books in the world. But health data is the fastest growing area of data in all of that. 30% of data in the world's health data, and it's going up all the time. How are we going to deal with that? How are we going to cope with it? Well, I think we have to look to things like AI, and we have to look to things like AI because, as a very brief example, in southwestern Sydney, there's nobody here who's my boss or anything, so I'm okay, but when they put in place a monitoring system for patients after COVID, like many places did, they got this company that made a pulse oximeter with an app on a phone, which could actually take the data and transmit it to some central location. And what they did with everybody that went home, instead of actually doing something like giving to these people and setting it up so the apps automatically transmitted the data and get some AI algorithms built which would spot when somebody was sick or getting sicker. What they did instead is they employed about 150 nursing staff, and they sat them in a room and they got them to ring these patients twice a day and said, that sort of clothes peg thing you've got, put your finger in it and tell us what the number is. So they defiantly analogized a digital process that could have saved them millions of dollars and been far more effective at spotting people who are getting sick, and they did it in a way which was really rubbish. We're still a bit in the rubbish phase, unfortunately, and we've got to learn to do it better because the amount of data coming means we've got to work out ways to do it. This is Cerner FirstNet, that's in the middle. These are all the other databases in southwestern Sydney, some of which are sort of operational, some of which are clinical, and they're all those data silos. Okay, none of them are built to talk to each other. Even the Cerner ones don't talk to each other. So what we've done is this. We've taken all of those silos and we've joined it up into Cedric. And Cedric is our data linkage and analytic platform. It's a comprehensive epidemiological data set for research, innovation and collaboration. It's all patient presentations through South Western City EDs for just over a decade. And it's all the data from different places linked, including pathology, radiology, etc. It's got automated linkage, machine learning, etc. And there's 14 million patient presentations in it at the moment. And we're building other databases for those other specialties that will link up automatically with Cedric as well. And eventually we'll have a thing called a data fabric where you leave data in these databases and it gets linked together when you need it and you need to analyze it. And we've just put in now recently 70 million clinical documents. These are notes from you and me. These are discharge summaries as radiology reports to use natural language processing to pick out the various facts among them. So that's what we've got. ChatGPT, remember, gave us stuff about decision support, diagnosis, imaging, prediction, rehabilitation, recovery, and personalized medicine. So just before we give some examples, I'll just remind you about this. Some of you may know about it. This is called a receiver operating characteristic curve. Okay, that's sort of all you need to know about it, really. But what it means is it's plotting sensitivity versus sensitivity versus 1 minus specificity, which means true positives versus false positives. And a line straight across the middle means it's just as good as chance. And if it pushes up towards the left-hand side, it's much better than chance. And if it's right up in the top corner, it's absolutely brilliant. And it's got various measures, which I'll tell you about. You just need to know that. 0.7 upwards is regarded to be good to excellent. When you get above 0.9, as they call it, outstanding. So I'll charge you it because of this. This is one paper which looked at developing a deep learning model to predict intracranial hemorrhages. And it modeled these decisions. So it didn't do it live, but it used the National Trauma Registry. And it predicted these various types of intracranial hemorrhages, cerebral contusions and subarachs and intraventricular hemorrhages and all those things. It had an area under the curve for that ROC curve thing of 0.927. So better than any human, essentially, at identifying these things. It got a bunch of physicians, emergency physicians, to look at these cases, anonymized cases, and make decisions about them. And what it did, out of those 568 decisions, 200 were changed. But from those 200, there were 70% of CT scans that were ordered that it changed back to not ordered because you didn't actually need them because they didn't have a hemorrhage. There were 36% of patients who had CTs ordered that really needed them and they hadn't been ordered by the ED physicians. And it did something like save 11% of the CT scans that were ordered and ordered another 11% of ones that should have been done that not. So performed incredibly well in that simulation. In this one, another one looking at imaging. Imaging's where AI has been used for quite a long time now, and it's really advanced in imaging of various sorts. This study looked at non-contrast CTs from across UK, US and India. We had 3 radiologists who said this is the absolute truth. So this is a supervised model. And the neural network algorithm had 0.988, so that's almost 0.99, almost perfect. And again, completely superior to anybody else, to humans. And, excuse me, identifies and localizes 90% of false negatives for intracranial hemorrhage and 70% for acute infarcts. So pushing swiftly on. Another one looking at imaging. This study looked at 260 cases of non-contrast CTs with 70 patients with subdurals. It showed a median thickness of 11 millimeters and a minimal midline shift. So the neural network once again performed well by itself without any prompting from any humans. Okay, let's move on to prediction. And prediction for us is really important, of course, because we see undifferentiated patients, heterogeneous patients all the time. A lot of the stuff we talked about in the last 2 days has been about how do you tell when X is true or not, or how sick is that person. So prediction is core to what we do. And in this one, we used machine learnings predict the outcomes of traumatic brain injury treatment, but it evaluated all these things that we sort of think about but don't really do quantitatively, at least. So demographic features, social determinants of health, age, gender, marital status, even things geographically like average income in the places it came from, housing status, things like that. And obviously all the clinical features as well. And they used one of those decision tree models in 1,600 patients, and they showed that out of all of that, the most sensitive things for actually predicting the good outcome were, or a bad outcome, sorry, were the condition of the pupils, the cisterns on the CT, and the patient age. Those three things alone were highly predictive of mortality. And for later mortality, the motor part of the Glasgow Coma Scale, let's not forget that the E, V, and M all mean they're all looking at different parts of the CNS, and motor is really about integration of the brain and the spinal cord. And condition of the pupils and age, again, predicted mortality. Things that we wouldn't look at and say, oh, well, I think that they're 5 years older than those other ones, so they're definitely going to do worse. And this one looked at clustering. This is that thing that I said machine learning is quite good at, just dividing people up into different groups which have things in common. And they essentially looked at recovery, or they suggested that we should be looking at non-fatal outcomes in trauma, which is pretty fair. If you're in a wheelchair for the rest of your life, that's an impact that you're going to have, which is short of death, of course. So they looked at clustering patients based on their outcomes, on their longitudinal recovery, using machine learning techniques, and they looked at a combination of physical and psychological outcomes. They used 12 injury predictors, and they looked at length of stay, type of accident, etc. And they found that an organized combination of some physical and some psychological signs or factors were the things that predicted an outcome best, and either of the other two alone wasn't very effective. So these have all been done, okay? These are all things that are becoming mainstream. Maybe not where we work right now, but pretty soon. What was that? Sorry? Oh, I thought you said two. Anyway, coming soon. Right. Data mining to understand health status. This is the sort of stuff. Oh, sorry, let me just go back there. These are that long list, which I can't get back to, is some of the things that you take into account, or you should take into account when you're predicting some outcomes, to do personalized medicine, which is what everybody talks about, but nobody really delivers. These were the pieces picked out of that, the facts picked out, which had a major impact. And if you look at some of them, that if somebody had orthopedic injuries or potentially had adverse drug effects, it gave them 4 to 5 times worse outcomes. This is about patient decompensation. This is an area which I think is quite interesting, but essentially this looked at monitoring in the emergency department. It looked at blood pressure, pulse oximetry, ECG, coming from the monitors, being streamed into a clever system, and then analyzed by machine learning, and tried to use that to predict what was going to happen next. And what it predicted was a worsening or a new tachycardia, again with an area under the curve of 0.8, new hypotension, again 0.8, and new hypoxia 0.7. Not as perfect as the radiology things, but this told us, without actually us having to intervene, that these patients are going to get sicker imminently, and significantly outperformed models using just triage. And the last one I want to show you is this one. I'm going to try just to go back because I want... Okay. This is an old paper, right? This is 22 years old. And I put it up because it's something which still people don't actually get. And this said that in patients with a traumatic brain injury, a single episode of pre-hospital low blood pressure predicted a poor outcome. If you had, and it doubled the risk of a poor outcome. If you had 2 episodes of a low blood pressure pre-hospital, even if it was normal when they got to ED, they had 8 times the risk of a poor outcome. Who looks at the ambulance seat and, oh my God, look, they've had 2 episodes of hypertension? Nobody. But should we? Well, that would say yes, wouldn't it? What we should be taking into account is all of these different things that actually patients come to us with. We should be thinking about every single aspect of every variable associated with the patient journey, whether it's this, whether it's those things in the sort of sequential time series. These are actually, I looked at essentially the pieces of information on Cerner which were related to a patient that could be put into a model for traumatic brain injury. And this is the ones that we need to be able to use. Everybody here obviously analyzes all of these when they look at their patients, don't they? Obviously. But this is real. That's what actually we need to be taken into account. And finally, I just want to leave you with a couple of quotes in terms of what artificial intelligence may be. And this person said, the promise of artificial intelligence in medicine is to provide composite panoramic views of individuals' medical data, to improve decision making, to avoid errors, and to help in the ordering and interpretation of appropriate tests, and to recommend treatment. That was a guy called Eric Topol, who is a very famous sort of AI researcher. And finally, this was from Jan LeCun, who won the top prize in the world for AI innovation. And he said, our intelligence is what makes us human, and AI is an extension of that quality. Artificial intelligence is extending what we can do with our abilities, and in that way it's letting us become more human. So although there are worries about AI taking people's jobs or blowing up the world or doing something like the Terminator style of the movie, that's not what this is about. It could if we let it, of course, but AI is about doing the stuff that we can't do. Okay, it's about bolstering and supporting our activity, because AI doesn't have intuition. AI doesn't have 10 or 20 or 30 years of clinical practice in their head. AI doesn't have insight into humans. So AI is going to be a fantastic tool, but it won't get rid of us. Thank you.